Hey everyone, Dr. Steve here. You know it as well as I do, but most students need a B or better in A&P. But did you know that students are doing that all over the US using my Anatomy and Physiology Digital Suite as a low-cost alternative to expensive textbooks? Digital Suite delivers the key concepts of A&P with short, assignable tutor videos and a bulleted narrative study guide that not only explain the concepts of A&P, they show them happening. Combined with state-of-the-art dissection and physiology lab simulations and a vast question bank for quizzes, homework assignments, and exams, Digital Suite meets students where they are and gives them the tools to master the content. It's the perfect supplement to an OER textbook or just on its own. If you're an A&P instructor, contact your McGraw-Hill representative today and ask about Anatomy and Physiology Digital Suite. If you're a student, tell your instructor about it. There's a link to Digital Suite in the show notes of this episode. Get your B or better in A&P with A&P Digital Suite. Hey everyone, welcome back to my podcast, Anatomy and Physiology Bit by Bit. I'm your host, Dr. Steve Sullivan, coming to you from Bucks County, Pennsylvania, where I've been teaching A&P since 2002. This episode is part 2 of aging and senescence. In the last episode, we talked about the concept of senescence and covered what happens to the tissues of several organ systems as we get older. We finished with the circulatory system, and in this episode, we'll pick it back up with the immune system. But before we do that, I want to answer a listener question. Rachel in upstate New York in the United States asked how we can halt the aging process. That's a good question, Rachel, and it's asked a lot. I'm sure several of you out there would like to know the answer to this, and unfortunately, there are way too many people who are willing to take your money to give you the answer you want. But the reality is that at present time, there is no scientifically validated way to halt the aging process in humans. Aging is a multifaceted biological reality characterized by the gradual accumulation of molecular and cellular damage. This includes instability of our genes from accumulated DNA mutations, progressive telomere shortening that limits cellular replication, mitochondrial dysfunction that impairs energy metabolism, and chronic low-grade inflammation. These processes collectively drive 3 factors of aging: the decline in physiological reserve, increased susceptibility to disease, and ultimately, mortality. Now, I don't think I've talked about telomeres on this show before, so let me clarify what they are. Telomeres are protective protein and DNA structures at the ends of chromosomes that prevent degradation and fusion, acting like the little tips on the end of your shoelaces. They shield genetic information during cell division. With each replication, telomeres shorten, leading to a cellular aging and eventually cellular death, though this process can be reversed by the enzyme telomerase. This process is crucial for limiting the lifespan of individual cells while also preventing unchecked cancer growth. Now, we can talk about longevity, which isn't halting aging. Research in model organisms has revealed several pathways that appear to influence longevity. For example, calorie restriction in rodents reliably extends lifespan, and pharmaceutical interventions like rapamycin, metformin, and NAD+ precursors show promise in slowing the age-related decline in animals. However, these findings have not yet translated into proven therapies for humans. Human trials are ongoing, but they're often small, short in duration, or focused on surrogate markers rather than hard clinical outcomes such as morbidity and mortality. So they're not quite valid evidence as of yet. What we do know, and what is strongly supported by decades of epidemiologic and interventional evidence, is that lifestyle optimization can meaningfully alter the trajectory of aging. Here are some things you can do. Regular physical activity helps preserve lean muscle mass, bone density, cardiovascular function, and insulin sensitivity. A nutrient-dense dietary pattern reduces oxidative stress and lowers the incidence of metabolic and cardiovascular disease. Adequate restorative sleep supports immune and endocrine function. Avoidance of smoking and moderation of alcohol intake significantly reduce cumulative toxic injury. And finally, take preventative measures to avoid disease or catch disease early. This includes routine vaccinations to prevent contracting or lessen the effects of infectious disease, cancer screenings for early detection, and early management of chronic. These are just some of the things we can do to extend not only lifespan, but also healthy lifespan. Now, it's equally important for me to emphasize what the evidence does not support. The commercial market for so-called anti-aging supplements and therapies is vast, but many of these products are marketed with bold claims that far exceed the scientific evidence. Consumers, students, and future healthcare practitioners must be cautious about interventions that are not supported by rigorous clinical trials. And be wary of healthcare practitioners that recommend, endorse, or worse, sell them. They're all over social media. In fact, some antioxidant supplements, once believed to be beneficial, have, in large randomized studies, shown little effect or even potential harm when taken in excess. So, Rachel, the most responsible answer is this. Aging cannot be stopped, but it can be influenced. The clinician's role is to guide patients toward interventions that are evidence-based, safe, and effective, while helping them remain skeptical of unsubstantiated promises of longevity. At the same time, we should remain informed about emerging research in particular areas. There is research going on with drugs called senolytics that are intended to suppress senescence. We also have epigenetic reprogramming. So without going into too much detail now, epigenetics studies the inheritable changes in gene expression that do not involve mutations of DNA sequence itself, like we see in evolutionary adaptations. Instead, epigenetic mechanisms act like switches or markers that control when, where, and how much genes are expressed. Key mechanisms include DNA methylation and histone modification, where chemical tags turn genes on or off by changing how tightly DNA is coiled and packaged. Environmental factors, lifestyle, and developmental processes can all influence the epigenome, affecting everything from cell differentiation to disease susceptibility. And then there are metabolic interventions, because while these approaches are not yet clinically ready, they represent exciting frontiers in the biology of aging. For now, the best anti-aging strategy remains comprehensive lifestyle optimization and preventative medicine, not unproven pills or miracle cures. Rachel, I hope this answers your question, even though the answer may be a bit disappointing. We'd all like to find the fountain of youth. Trust me, I'm with you on that. But unfortunately, it doesn't exist. Thanks again, Rachel. Having said that, I'd like to say something real quick before we continue on with aging and senescence. I should have said it in the last episode. But I'm simply going through the changes we typically see on average as we get on in years. Some of this may seem like a lot of doom and gloom, but it shouldn't. Like I said before, there are many things we can do to make sure things happen more gradually and don't peak until we're much older. Senior citizens are living full, exciting, and healthy lives all over the world because they're doing the right things to take care of themselves and because of advances in modern medicine. So when you hear the rest of this episode, keep in mind that these are the physiological changes that can occur and some diseases that are most common as a result. They are not all certainties for every individual. And there are some well-known measures we can all take to limit the ones we experience. Okay, let's get back to aging and senescence, and we'll pick it up with the immune system. Since the immune system is a system of cells rather than a system of organs, let's take a minute to review some of the structures where those cells tend to congregate, the lymphatic organs. Recall from episode 50 that the main lymphatic organs are the thymus, spleen, lymph nodes, and tonsils. Throughout childhood and in early adulthood, the thymus degenerates. By the 7th decade, only small islands of thymic tissue remain, and T-cell selection and education operate at a fraction of their capacity from when we're younger. Parallel changes occur in other lymphoid organs and in red bone marrow. For example, we see a decline in the total number of hemopoietic stem cells and a decrease in the numbers and functional quality of leukocytes and antigen-presenting cells. Lymphocyte development more often fails at maturation checkpoints, so fewer fully competent clones reach the periphery of our bodies. Clinically, we see a broad decline in immune function. Antigen presentation is less frequent and less effective. CD4 plus T cell help is less robust. And antibody responses tend to be lower and slower to develop. Immunosurveillance of tumor cells becomes less sharp, and pathogens encounter longer windows in which to gain a foothold. What does this all mean? As we get older, we become more susceptible to infection and cancer. Therefore, vaccination remains essential across the lifespan. Even though our immune system may not react to the vaccines as virulently as they do when we're younger, we still need to get them. At the population level, reduced immunity among people who are around a lot of other people, think long-term care facilities, enhanced living environments, and frequent hospital visits, these can create conditions where transmissible infections can spread easily and produce disproportionate morbidity. I should take a second to explain the difference between morbidity and mortality. You'll hear me use those terms, and you'll probably hear those terms in your own studies. Morbidity refers to the state of being unhealthy or in a disease process, whereas mortality refers to death. So morbidity rates are the rates of the number of unhealthy people or people who are currently dealing with disease. Mortality rates are the rate of actual deaths. We should also consider cancer screenings. It's very important to catch these things early. So frequent, regular screenings are important for longevity. So many cancers can be treated successfully when caught early. Next up, the respiratory system. This is a big one for the elderly. Beginning in the third decade, pulmonary performance drifts downward. Costosternal and costovertebral joints stiffen, the elastic fiber network in the lung tissue thins, and the number of total alveoli falls. There are multiple consequences of these events. Vital capacity declines. This is the amount of air you can move in one maximum inhale and exhale. There's also a drop in the amount of air you can exhale in 1 second, or FEV1. This is directly related to the degeneration of elastic tissue in the lungs. Recall from episodes 51 and 52 that at rest, exhalation, or expiration, is passive. You shouldn't have to spend any energy exhaling because the elasticity of the lungs naturally recoils when we relax our diaphragm. So the more the elastic tissue degenerates, the more effort it takes to exhale. Imagine if every time you exhale, it's like you're blowing up a balloon. This is what having emphysema is like, and we're going to talk about that in a little bit. Maximal minute ventilation decreases as well. This is the amount of air you can move in and out of your lungs in 1 minute. The ability of the respiratory system to protect us from inhaled particles and pathogens erodes as well. The mucociliary escalator is not as effective, making it harder for us to clear inhaled particles that are trapped in mucus. And that is compounded by a decline in what is called the cough peak flow. This is the maximum force of a cough. The older we get, the weaker the intercostal and abdominal muscles get, resulting in a weaker cough. So it's harder to get the stuff out. The result is that microbes and particulates that get trapped in the mucus don't get removed by the tracheobronchial tree as readily as they used to, and instead they make their way into the alveoli, causing pneumonia, which is an infection that results in inflammation of the alveoli. Clinically, pneumonia is one of the leading causes of death among the elderly. Now, the fourth largest cause of death in the world overall is called chronic obstructive pulmonary disease, or COPD. This is a term that encompasses emphysema and chronic bronchitis. Emphysema is a degeneration of the lung tissue causing the loss of elastic tissue, which I mentioned earlier, as well as a decrease in the total surface of alveolar membranes. So it's not only a decreased ability to exchange carbon dioxide for oxygen, but also to expel the carbon dioxide from the lung. Bronchitis is characterized by inflammation of the bronchi and bronchioles. This leads to excessive mucus production and a persistent cough. If the cough lasts for 3 months and this happens for 2 consecutive years, it is diagnosed as chronic bronchitis. COPD restricts oxygen delivery and exercise tolerance. It also increases right and left heart strain and accelerates hypoxic injury in downstream organs. This means the decline in oxygenation of the blood results in damage to the organs that blood supplies. Number one cause of COPD by far is cigarette smoking. 75% of all COPD cases are with people who have a history of smoking. For emphysema specifically, that number can climb to 90%. And this isn't a quick, painless way to go. It drains the life out of someone over the course of several years. Imagine being exhausted from breathing. That's COPD. Having to bring oxygen with you everywhere you go, having to sit down and take a break from walking one block, it robs people of the quality of life that is possible in the later years. If you're a smoker, stop. I know it's not easy because cigarettes are addictive, but find a way. If you're not a smoker, keep it that way. Personally, I watched my father slowly decline over the course of 10 plus years. He smoked most of his life, and that resulted in COPD that took away most of the functional life he could have had in his late 60s and 70s. I hear people say all the time, well, you got to go somehow. This isn't the way you want to go. Trust me. Okay, let's get to the urinary system. Episodes 53 to 55 cover the urinary system in this podcast. From about ages 25 to 85, the number of nephrons, the functional units of the kidney, falls by roughly 35%. Among the remaining glomerular blood vessels, we see atherosclerotic change and progressive glomerulosclerosis, meaning the lumina of the vessels narrow and lose their elasticity, impeding blood flow. The overall mass of the kidneys can shrink by up to 40%, and the flow of renal blood plasma is cut in half. This means a proportional decline in glomerular filtration rate, which is the measure of kidney function. This remaining renal function may be enough for a person when they're having a good day, but under stressors like an illness, dehydration, side effects of common medications, etc., renal performance can deteriorate quickly. The management of medication must consider the reduced clearance capacity of the kidneys. If it doesn't, the components of those medications can accumulate and cause toxicity. Water balance is more fragile. Kidneys respond less vigorously to antidiuretic hormone, thirst perception is blunted, and even with free water access, many older adults drink inadequate amounts of water. This causes hyperosmolar dehydration. That means the concentration of solutes in the blood plasma is too high. You've probably heard of people on dialysis. Dialysis is the term for what the kidneys do. When someone is in renal failure, where their kidneys are not functioning at a high enough level to sustain their health, they may need to do external dialysis, which means they have to go to a dialysis center, sometimes 3 days a week, and they sit there while their blood is pumped into the machine, and the machine does for them what their kidneys would normally do. Among older people, urinary bladder and urethral symptoms are the rule, not the exception. In biological males, we often see benign prostatic hyperplasia. This is a non-cancerous growth of the prostate. Since the beginning of the urethra travels through the prostate, it gets pinched, narrowing the urethral lumen. The result is an impeded flow of urine, predisposing them to an inability to empty the urinary bladder satisfactorily, and it could cause an infection. If the urinary bladder gets too full, urine can actually back up into the ureter and cause injury to it and/or the kidneys. This is why you hear about biological males as they get older having to use the bathroom so much, even in the middle of the night, because when they do go, they don't empty their bladder all the way. So the next time they have to go is sooner than it would have been otherwise. In biological females who've had children, pelvic floor laxity can sometimes cause incontinence, which is difficulty holding urine. The loss of estrogen also contributes. These symptoms are not trivial annoyances. They drive social withdrawal, disrupt sleep, contribute to moisture-associated skin damage, and can cause fall risk. The more often someone has to get up in the middle of the night to use the bathroom, especially in the dark, the more at risk they are for tripping and falling. Okay, let's move on to the digestive system. Energy requirements as we get older decline due to a lower basal metabolic rate and activity level. However, appetite often declines even more. Combine that with diminished senses of smell, taste, and vision, and the appeal of food makes meals less rewarding. It's also common for the elderly to have a decrease in salivary gland function, causing xerostomia, which means dry mouth. Xerostomia makes chewing and swallowing more difficult and increases the risk of dental issues. Dentures, periodontal or gum disease, thinning oral mucosa, atrophy of the muscles of mastication, and mandibular bone loss can also make chewing more difficult and uncomfortable. Not to mention the practical burdens of shopping and cooking for older people who can't get around as easily as they once could. That makes it feel like it's not worth it to prepare meals that they don't feel are appetizing anyway. Despite the lower caloric requirement, the need for micronutrients like vitamins and minerals is still there. At the same time, micronutrient intake falls and absorption becomes less efficient, creating a twofold deficit of the vitamins and minerals required for optimal metabolism. Common digestive conditions include atrophic gastritis, which is an inflammation of the stomach that causes a decrease in the number of gastric glands and cells. With fewer gastric glands, you get less hydrochloric acid secretion, which is called hypochlorhydria. This leads to a reduction in calcium, iron, zinc, and folate absorption. You also get a decrease in intrinsic factor secretion, compromising vitamin B12 absorption, which can cause pernicious anemia. You've probably heard of GERD, G-E-R-D, gastroesophageal reflux disease. This is when the lower esophageal sphincter between the distal esophagus and the cardia of the stomach weakens, allowing acidic gastric juice to backtrack into the esophagus and irritate its unprotected mucosa. Since the esophagus is adjacent to the heart, the pain and discomfort can feel like the heart is burning. So people call it heartburn. But it has nothing to do with the heart. The most common digestive symptom in older people is constipation. This is a result of a combination of things: age-related loss of muscle tone in the colon's muscularis externa, less effective neurotransmission in the enteric nervous system, low dietary fiber and fluid intake, and reduced activity. All of these slow down the movement of feces in the colon, potentially leading to hard stools, straining to evacuate the bowel, and hemorrhoids. Because of this, people tend to avoid using the bathroom, which reinforces the constipation. The liver, gallbladder, and pancreas typically show a modest functional decline, but drug metabolism by the liver can slow substantially, so medication doses may need to be adjusted to avoid an overshoot effect. Okay, we don't typically think of the reproductive system when we're talking about people in their 70s, 80s, and 90s, but it's still a physiological reality. In biological males, reproductive aging is gradual. Testosterone levels trend downward, and sperm counts, semen levels, and sex drive also decline. Fertility can persist, but erectile dysfunction becomes increasingly sensitive to vascular disease, antihypertensive and psychotropic medications, and mood disorders. In biological females, we have menopause, which I discussed in detail in episode 70, so I won't rehash it all now, but if you want the details, that's where you can get them. In summary, not only does ovulation cease, but genital tissues atrophy, lubrication decreases, and sexual activity may become uncomfortable without intervention. Estrogen deficiency elevates bone turnover and fracture risk, and worsens cardiometabolic risk profiles. Effective care is practical and preventative. It includes addressing bone protection, sexual health, cardiovascular risk modification, and the genitourinary syndrome of menopause early and explicitly. Okay, doom and gloom over. Let's talk about what we can do about it. Among interventions that counter functional decline, physical activity has the broadest evidence base. Even modest, sustained exercise programs combined with healthier behavior correlate with several added years of average survival. For example, endurance training boosts stroke volume and cardiac output, raises VO2 max, and reduces body fat mass. Resistance training preserves and can increase muscle mass, strength, and power, arguably the single best strategy to prevent falls and osteoporotic fractures. Now, I'm not prescribing exercise to anyone individually. You should consult your own physician before beginning any exercise program. And I'm not giving medical advice. However, research has shown that a reasonable exercise program includes 3 to 5 aerobic sessions per week, lasting approximately 20 to 60 minutes each, and targeting about 60 to 90% of maximum heart rate. Obviously, your physician will evaluate individualized risk and, when appropriate, exercise testing. Also showing promise is at least 2 weekly resistance sessions covering major muscle groups and progressive balance, flexibility, and speed drills with advancing age. Programming for older adults should start low and go slow. Include pre-participation screening for ischemia and arrhythmias when indicated, emphasize hydration and heat management in light of impaired thermoregulation, and require deliberate warm-ups and cool-downs to limit musculoskeletal injury and hemodynamic swings. Importantly, meaningful gains are achievable even into our 80s and 90s. Neuroplasticity and muscle plasticity still persist, albeit with lower ceilings and slower rates of change. Okay, so let's wrap it up on aging and senescence with a quick summary. Aging is not a single organ diagnosis. It is an ecosystem phenomenon. Effective care requires integrating cardiology with endocrinology, neurology with rehabilitation, dermatology with nutrition, and pharmacology with home safety and social supports. Everything needs to be considered. It calls for weighing survival alongside function and function alongside meaning. In older people, we see layers. What the skin reveals about sun and nutrition. What gait implies about muscle, nerve, vestibular function, and vascular supply. What the medication list says about a lifetime of accumulating diagnoses and prescriptions. When we get older, we need to talk to our physicians and together decide which medications are still doing what they're supposed to, where progressive strength and balance work could restore autonomy, and how a minor home modification could erase a major hazard. We cannot turn back the clock, and there is no validated path to exceed the current human lifespan ceiling. But by understanding how organs age, how systems amplify one another's weaknesses, and how preventative choices compound over decades, we can turn the cliff of senescence into a gradual slope. More good days between illnesses, more comfortable breaths between hard ones, and greater agency near the end of our story. Okay, so in a traditional A&P textbook, this would be the end. But I've got a few more topics I want to cover before we shift gears into specific pathologies of the human body. So keep your eyes open on upcoming episodes about genetics, evolution, and exercise physiology. Once again, I want to thank Rachel in upstate New York for emailing me her important question. I didn't ask where in upstate New York. I used to live in upstate New York. The Finger Lakes specifically, which is really kind of central New York. But, upstate's upstate. Anyway, Rachel, I hope my answer helped. And of course, I want to thank you, the listener. I hope this podcast is helping you get your B or better in A&P. Good luck on your next exam, and I'll talk to you next time.